Yeah, first of all, I would like to thank you all for coming on a Sunday for an academic session, and also Rajshekar sir for giving me this opportunity. Again, this is some sort of a back to basics talk only. Maybe I hope to cover an extensive topic in a little short duration. So then, I'm sure all of you have worked in ICUs and you have had experience with this cardiac arrhythmias at some point of time. The point with these cardiac arrhythmias is, the cardiologist seems to be cool about it. The rest of the intensivists, anesthetists, and all are quite alarmed about it, and they would like to us to do something. They just want to see a normal and a completely good ECG. But then the trick is there is a wide range of presentations. Some patients may be totally asymptomatic. Some patients may actually go on to have a cardiorespiratory arrest. So it's also important that we develop a framework to assess and manage. How do we train our sisters? How do we train our intensivists? How do we train ourselves to pick up these things, pick up the danger signs, and then assess and come up with some management protocols. We have a significant incidence. Up to 12% of our ICU patients will have some kind of arrhythmia. Around 8% are SVTs, 8% are VTs, and up to 2% have some kind of blocks. So arrhythmias are associated with higher incidence of death, neurological sequelae, and morbidity. And then the problem is there is a varied mix of pre-existing conditions. Some of these patients already have some heart disease. Some of them have some comorbid conditions which contribute to arrhythmia. They have an ongoing metabolic disturbance. There are septic conditions which all lead to an increased incidence of arrhythmia. So sometimes it's difficult to to identify what is the dominant presentation in that particular case. So, like as previously said, we need to establish management protocols. We need to establish, because nowadays even emergency EP is available. We should also consider ablation as a form of management. So we should be able to escalate these patients relatively fast instead of waiting too long. So the origin of arrhythmia is cardiac or systemic. In the cardiac, we have the conduction system, which is the most important culprit, the SA node and the AV node, and also ischemia, such as inferior wall MI, we keep seeing quite often. Then congenital heart disease. Then we have these axillary pathways. We have pathways which have different properties of conduction which lead to arrhythmias. Then some prior injury to the heart in the form of cardiomyopathy, and some genetic channelopathies, and sometimes patients on pacemakers, ICDs and all, they also have some kind of arrhythmias as a result of some machine malfunction or machine overinterpretation or something. In the systemic processes, we have hypothermia, hypokalemia, head injury, drugs, toxins, sepsis, pyrexia, pneumothorax, pulmonary embolism, consolidation, even pain, catecholamines, vagolytics, hypoxia, hypercarbia. These are all in some ways contributory to arrhythmias. In the structural kind of, where the damage is more permanent, more fixed, it is most often because of a prior myocardial infarction. Myocardial infarction in the acute form, in the healed form, in the aneurysmal form, all these is associated with higher incidence of arrhythmias. Then the hypertrophy of the ventricles or the chambers, the dilatation of the chambers, fibrosis. So these are structural changes which give rise to arrhythmias. Now some of the more transient changes that are there, that is ischemia and reperfusion, hypoxia, acidosis, electrolyte imbalances, autonomic tone, endogenous and exogenous catecholamines, that is the NORAD or the adrenaline and all that we keep giving, proarrhythmic drugs. So some drugs we give with certain intention, but we like tricyclic antidepressants or antifungals, so they all turn out to have some proarrhythmic properties. So ultimately it's a combination of abnormal automaticity, slowed impulse conduction, premature contractions, which all contribute to arrhythmia. So again, for any cardiac condition, we would like to go with the stepwise approach. We would assess for hypotension, hypoperfusion, consciousness state of the patient, syncope, ischemia in the form of chest pain or ECG changes, pulmonary edema, JVP. So the point is, the patient's urgency depends upon his clinical condition. If he does not have any of these, we have some time to, we don't have to rush to invasive treatments and that kind of thing. Also a quick check, airway, breathing and circulation, supplemental oxygen, non-invasive blood pressure, pulse ox, venous axis, 12-lead ECG as soon as possible, and stick on defib paddles. I mean, we should make sure that they're on the patient. And they should also have this pacing backup facility if at all we are going to cardiovert at all. Then arterial blood gas analysis, potassium, magnesium, calcium. So this is a checklist we run for any patient with a potential arrhythmia or a patient in arrhythmia. So first we deal with the bradyarrhythmias. Bradyarrhythmias are when the heart rate is slow, and it's the way we classify bradyarrhythmias is as per the relationship of the QRS and the P waves. So when you have a regular relationship, that is sinus bradycardia or a first degree AV block or a Mobitz type 1 AV block, irregular it is complete heart block, Mobitz type 2 AV block, or an absent relationship, there are no P waves to see, that is an AF with a slow ventricular rate. So the conditions that contribute to bradyarrhythmias are hyperkalemia, intracranial pathologies. We see the Cushing's reflex, dengue. We have seen quite often they have severe bradycardia and also some drugs. So we assess for the symptoms. Again, it's important to see whether the bradycardia is symptomatic or it is just an incidental finding where a patient is pouring urine, maintaining blood pressure, no low output symptoms. Vis-a-vis a patient who is actually acidotic, he is hypotensive. So we need to make that call. So that we strategize the patient's management. Atropine is the first drug of choice. We give 0.5 milligram IV, up to 3 milligram, 0.5 milligram or 500 micrograms. We can give up to 3 milligrams in aliquots. Then we have to consider temporary pacing.